Nausea and vomiting. Scenario: a 77-year-old woman was initially admitted with chest pain, and during the course of investigation is found to have iron deficiency anemia. She is given bowel preparation for a colonoscopy and starts to vomit. You are asked to assess her. Introduction. Nausea and vomiting are very common nonspecific symptoms that occur in many medical situations. Nausea is a feeling of inclination to vomit and may be associated with hypersalivation and/or regurgitation of small amounts of material from the stomach. Vomiting is not always associated with nausea. Both may be stimulated via many mechanisms within the body, ranging from the higher centers, e.g. unpleasant visual stimulus, to toxic causes, e.g. chemotherapeutic agents, to mechanical causes, e.g. intestinal obstruction. Table 16 shows causes of nausea and vomiting classified with respect to mechanism. The scenario described is very suggestive of intestinal obstruction that has been precipitated by the bowel preparation, but it is important to consider other causes. Some preparations used for bowel preparation have an unpleasant taste and many patients experience nausea whilst taking them. There is also a history of chest pain, about which no details are given, but this may be cardiac and hence it will be important to exclude the rare but important diagnosis of painless myocardial infarction presenting with vomiting. History of the presenting problem. When did the symptoms start? A long history of recurrent vomiting may suggest that this is an acute on chronic exacerbation of a known condition such as diabetic gastropathy. Identifying a temporal association with a procedure, new drug, or other event may be crucial in diagnosing the underlying problem. What was in the vomitus? Vomit is usually partially digested food mixed with gastric juice. The presence of small amounts of blood is not unusual, particularly if there has been considerable retching, but large volumes of blood should lead to consideration of causes of hematmesis. Bilious vomiting may occur in patients who have had previous gastric bypass surgery. Vomiting of food from several meals ago may suggest gastric stasis or gastric outlet obstruction. What was the volume of the vomitus? Large volume vomiting occurs in small bowel obstruction. Is there any abdominal pain? Abdominal pain and vomiting should lead to consideration of other specific causes such as peptic ulceration, acute pancreatitis, or perforated viscus. Radiation of the pain towards the chest or down the arms would raise suspicions of a cardiac cause. Has there been any change in bowel habit? This may suggest serious underlying pathology such as colonic neoplasia but is also seen in patients with infective gastroenteritis. Has the patient passed stool or flatus? Reduced bowel opening or absolute constipation is suggestive of intestinal obstruction. NB. Intestinal obstruction leads to different symptoms depending on the level of the block. Esophageal obstruction, dysphagia and inability to swallow saliva. Gastric obstruction, may cause vomiting with little or no pain. Small intestinal obstruction, usually causes vomiting, but the colon may still function. Colonic obstruction, often causes pain and constipation, but vomiting may be a late feature. Is there any associated dizziness, lightheadedness, tinnitus, or change in conscious level? These may indicate a central cause for nausea and vomiting from either the vestibular system or central nervous system, but may also suggest severe fluid depletion leading to impaired cerebral perfusion. Other relevant history. Has there been any previous abdominal surgery, which could lead to adhesions that might cause intestinal obstruction? Does the patient have any other medical or surgical conditions? She was admitted with chest pain, which might be attributable to angina provoked by anemia. and since acute intestinal obstruction may require surgical intervention, it is very important to identify comorbid risks such as ischemic heart disease at an early stage. It will be important to ask carefully about current medications and any recent changes in these. Drugs are a common cause of nausea and vomiting, and patients taking drugs that affect vascular responses, e.g. beta blockers, may be susceptible to smaller losses in circulating volume than would otherwise be the case. An alcohol history is also important. Alcohol excess or abuse is associated with nausea and vomiting, as are many of its complications, e.g. acute pancreatitis. Examination. General features. NB. Does the patient look well, ill, very ill or nearly dead? If the latter, then urgent attention and intervention are required. Get senior help early. An experienced hand carries extra authority when negotiating with other colleagues, e.g. in intensive care or surgical services, and is also important when decisions to limit intervention are appropriate. Check vital signs. Look in particular for evidence of volume depletion, cool peripheries, tachycardia, hypotension, postural hypotension, low JVP, and of sepsis, which can cause vomiting. Check pulse oximetry. NB. If the patient is peripherally shut down and hypotensive, insert 2 large bore cannulae and start resuscitation immediately whilst completing the history and examination. Check Glasgow Coma Scale, GCS, score. Reduction in conscious level may occur in the very ill, or it may indicate the underlying cause of vomiting, e.g. intracerebral lesion. Patients in coma, GCS less than 8/15, need definitive airway protection as they are at high risk of aspiration of gastric contents. Given the clinical suspicion of possible malignancy, look for clubbing, cachexia and lymphadenopathy. General examination should also focus on any significant comorbidities that might influence or preclude subsequent investigations or treatments. NB. Never lose sight of the whole patient. After initial resuscitation, do not focus exclusively on the main problem. Abdomen. Systematically consider the following. Inspection, scars, consider adhesions, distension, abnormal bruising, Cullen's or Gray-Turner's sign in acute severe pancreatitis. Palpation. Signs of peritonism, abdominal mass. Auscultation, high-pitched bowel sounds, obstruction, absent bowel sounds, perforation, succussion splash, gastric outlet obstruction. Digital rectal examination, presence of malaena, mass lesion, or fecal impaction. Investigation. The appropriate strategy for investigation will clearly depend on the clinical context. The patient who begins to vomit after being given a new medication may not require any investigation at all, but in the scenario described, the following would be appropriate. Routine blood tests. Check FBC. Electrolytes, renal, liver and bone profiles, amylase, may sometimes reveal the cause of nausea and vomiting, e.g. hypoatriemia, hypercalcemia, or its effects, e.g. hypokaliemia, useful in estimating the degree of dehydration, when urea is proportionally elevated to a greater extent than creatinine, also in excluding acute, or acute on chronic, renal impairment. Abnormal liver blood tests may suggest a biliary cause for vomiting. Elevated amylase would clearly raise suspicion of acute pancreatitis. Routine imaging tests. An erect CXR should be performed in those with abdominal pain to exclude a perforation by looking for free air under the diaphragm, and may also reveal evidence of aspiration pneumonia. A plain abdominal radiograph is essential in those whose vomiting might be due to intestinal obstruction, as in this case, Fig. 10. Other tests. Given the patient's history of chest pain, a 12-lead ECG should be performed to look for evidence of myocardial ischemia, and this may need repeating after 8-12 hours to assess for evolving changes. Also check serum troponin. Other investigations will be determined by the clinical context and the results of preliminary tests. Arterial blood gas analysis is required in any patient who is very ill and may reveal metabolic alkalosis if vomiting has been long-standing. Other structural investigations may be useful in selected cases. Ultrasound scanning, particularly good for imaging the gallbladder and proximal biliary tree, and can be useful in excluding intra-abdominal fluid collections. CT scanning, increasingly used in the investigation of acute abdominal pathology, particularly useful in imaging the pancreas and distal biliary tree, but can also reveal other gastrointestinal or non-gastrointestinal pathology. Endoscopic retrograde cholangiopancreatography, ERCP, and magnetic resonance cholangiopancreatography, MRCP imaging of the biliary tree by these techniques may be required in some specific settings, e.g. acute gallstone pancreatitis, where emergency ERCP with duct drainage is essential in reducing further complications. This should preferably be performed within the first 24 hours as edema at the papilla worsens over time, reducing the likelihood of successful intervention and increasing the risk of ERCP-related complications. Contrast studies. Patients with persisting symptoms may require either barium meal or small bowel enema and enteroclysis, which can give information relating to the extent of strictures in the small intestine in addition to assessment of the degree of small bowel obstruction. NB. If in doubt, get a surgical opinion. This can wait until blood test results and preliminary imaging studies are available if the patient is not very ill, but if the patient is shocked, call for advice as soon as resuscitation is underway. NB. Upper gastrointestinal endoscopy contributes little to the investigation of nausea and vomiting, without hematmesis, and is not without risk. The patient may have a stomach full of fluid, increasing the risk of aspiration and reducing the chance of visualizing any significant pathology. Management. Specific management will clearly be dictated by the particular cause of vomiting, but there are three main areas to consider in the management of all patients with this symptom: resuscitation, control of pain, and control of nausea and vomiting. Resuscitation. NB. Resuscitation is the most important aspect of immediate management. If the patient is shocked, i.e. has cool peripheries, tachycardia, hypotension, or severe postural hypotension, lying and sitting, and a low JVP, then give high-flow oxygen and insert large bore cannulae into both forearms or antecubital fossae. Give a rapidoid bolus, 1 L of 0.9% saline or colloid. Check peripheral perfusion, pulse rate, BP, and JVP in response to oid bolus. If there is still evidence of hypovolemia, give another rapidoid bolus. Repeat until the peripheries are warming, pulse is settling, BP is restored, without postural drop, and JVP can be seen. Insert urinary catheter to monitor urine output. NB. Many doctors worry about administering fluid boluses, particularly in the elderly or in those with a history of heart failure. It is true that both groups will not cope well with fluid overload, but both tolerate hypovolemia poorly, and so prompt volume replacement is important. Give rapid boluses of 500 ml rather than 1 L and check regularly for signs of fluid overload. Central venous lines. Central venous catheters take time to insert, do not themselves make anyone better, and attempts to insert them are much more likely to cause harm than benefit in a patient who is clearly hypovolemic. NB. Do not attempt to insert an internal jugular or subclavian central line into someone who is obviously hypovolemic. When they have been resuscitated, a central line may aid continuing fluid management. Pain control. Patients with pain should be given sufficient analgesia. If they are vomiting, then the drug should be delivered by a parenteral route, either intramuscularly, intravenously or subcutaneously depending on the circumstances. Opiates titrated to the level of adequate analgesia will often be necessary for severe pain. NB. Opiates cause nausea and vomiting in many patients and should therefore always be administered with an antiemetic. Control of nausea and vomiting. Control of nausea and vomiting is best achieved by identifying the underlying cause and treating this specifically. However, in most cases the exact cause may not be instantly obvious or there may be a delay in obtaining relevant information, in which case effective symptom control depends on determining the mechanism or mechanisms of nausea and vomiting in the particular case and selecting the relevant therapeutic intervention, Fig. 11 and Table 17. In the patient who is nauseous but not vomiting, oral medication may be sufficient, but once the patient starts to vomit, this route is no longer viable. NB. Insertion of a nasogastric tube may be necessary to relieve the symptoms of large volume vomiting and also allows accurate measurement of fluid loss. Other useful drug therapies include hosinbutyl bromide, which can be employed to reduce intestinal secretions, and octreotide may be used in a similar fashion. These drugs are used most commonly in patients with complications of advanced cancer.